All right, Elizabeth, can you hear me okay? Elizabeth, apparently not. Can you hear me okay or no? Can you hear me okay? Okay, all right, let's go and get started. Welcome to all of our new interns. Welcome back to new seniors, and welcome back to old seniors as well. I'm going to cover some issues related to mechanical ventilation. It's a topic which, of course, only applies to a fraction of our new interns right now, but will apply to everybody rather shortly. Between our units and your cross-covering responsibilities at night, and even the fact that on the floor, one of your patients may need to be intubated, and you may be the first person setting up vent settings. There's some reason for everybody in the room to suffer through a discussion of ventilators. This information will be available online, plus on our website, under the MICU curriculum, there's an entire ventilator manual, which one of our third-year fellows now, Katie Young, put together over the last couple of years. So that's a good resource as well. What we're going to talk about are basically initial ventilator settings, your daily assessment of the ventilator and how you should report your patient's ventilator settings. We're going to go through some troubleshooting things, because that's largely what interns do. And if time allows, we'll kind of cover a little bit of the basic approach to weaning, because that's one of Loyola's specialties. All right, we're not going to cover today some of the unusual modes. We're not even going to talk about reasons for intubation, BiPAP, et cetera. That's a talk for another day. All right, so this is what all of our ventilators look like. Actually, that's not true. We now have a new model coming in. But the vast majority of our ventilators look like this, okay? So when you walk in a room and they're attached to the ventilator, there's different components. The top half of it is what's actually happening. There's a bar across the top that says whether the particular breath was a triggered breath, a mandatory breath, et cetera. What the absolute total respiratory rate is, et cetera, a number of various things. And there's also these graphs, which we're going to go through in a little bit. So the top is what's happening to the patient. The bottom part are your settings, okay, where the orders you write, the respiratory therapist then uses this section to plug in the mode you want, the rate, volume, all of those other things. I emphasize that you write the order and then the respiratory therapist actually puts these into the ventilator, because you should not touch that area, okay? At some point between today and when you write your second textbook of critical care medicine, you'll touch the ventilators, but it's not today. All of you in the last 6 months went on a bunch of interviews, staying in a bunch of kind of random hotel rooms where you had to get up on time the next morning for your interview. And in order to get up on time, how many of you trusted your ability to set the alarm clock to get up in the morning? No, you set your iPhone, you had your mom call you, you asked for a wake-up call, from the hotel staff. No, that's an alarm clock. This is life support, okay? Don't fiddle with it. And there's even more restrictions on this presently than used to be the case. In some of our ICUs, they even don't want board-certified critical care attendings touching the settings on the ventilator. So please don't. You can get into a lot of trouble. Now, if you're with a pulmonary fellow and they say do things, et cetera, sure, for learning purposes, but on your own, do not fiddle with any of the settings, okay? Hate to be very draconian about that, but you can get in a lot of trouble. More importantly, patients can get into a lot of trouble, so please don't fiddle with anything at the bottom part of the ventilator, okay? Then at the very bottom part are some buttons. You will press some buttons. There's 2 buttons on the bottom called the inspiratory and the expiratory pause button. We will go through those in just a little bit, but probably the most important thing is to know where the silence button is. If the ventilator is beeping for some reason and you press the alarm silence button, it'll stop beeping for 2 minutes, which generally is long enough for you to get out of the room. So that when the nurse comes in and finds it beeping, you're not blamed for whatever was happening. Okay, so this is what all of our ventilators look like. When patients get intubated, you have to provide settings, and all of them have an FiO2 and a PEEP, but the main thing that is kind of a little bit confusing for folks who haven't worked with ventilators is the mode. There are a bunch of mode options. The 2 that you're going to see used almost entirely in the Department of Medicine are assist control, volume control, or assist control, pressure control. Those 2 are used quite frequently, and depending on which you pick, you have to set some other things that we're going to go through. There are a bunch of other modes, by much less commonly, that may not be entirely accurate, but much less commonly used as an initial mode. You will see VC plus pressure support, SIMV plus pressure support. in some settings. But if you know something about assist control volume control and assist control pressure control, you'll cover 95% of all the intubated patients in our department. And as I said, you always also have to set a PEEP and an FiO2. So let's spend a couple of minutes talking about the modes. All right, so to understand the modes, you have to think about how we're all breathing right now. I don't think anybody in the room is intubated right now. So when you take a breath in, you drop your airway pressure, and when you exhale, the airway pressure goes up. So if I intubated your chief resident, Maria Latz, up there, and measured the airway pressure versus time curve, when she breathes in, her airway pressure would go down. When she exhales, it would go up. Okay, that's the normal physiology. And on all of our ventilators, you will see at the top of it a airway pressure versus time curve. And you can see what's actually happening as described. So we're going to talk about our two major modes. An assist control, volume control. It has, first of all, it's confusing. It has a bunch of different ways of being referred to. Most old docs just refer to it as assist control. Some really old docs call it volume control. Even older than me would refer to it as continuous mandatory ventilation. The most proper term is ACVC because that's how our ventilator labels it. Assist control, volume control. In that mode, you set two things, a respiratory rate and a tidal volume. If you set a respiratory rate, it means the machine is going to do something at that rate. So every so many seconds, the ventilator will do what you told it to do. And in ACVC, what you tell the ventilator to do is to deliver a tidal volume. So every so often, based upon the rate you set, the machine will push in that tidal volume, the airway pressure would go up. What's described in this curve on the left is a mandatory breath, meaning you told the ventilator it's time to give that breath. To the right is what's called a triggered or assisted, hence the term assist control breath, where the patient, in assist control volume control, if they want an extra breath, all they have to do is start to breathe. It drops their airway pressure just a tiny bit, which is sensed by the machine to trigger the machine to give the same tidal volume it was going to give a moment later anyway. So you set a rate and a volume, you get a guaranteed backup rate, and all of the tidal volumes are the same size, the size you told it to deliver. Emphasizing that, how much work is it for the patient to trigger is almost none. If I took Maria with the ET tube in and strangled her, and she sucked in as hard as she could generate 100 centimeters of water pressure. The ventilator only requires 2 centimeters of water pressure generation to be triggered. 2 out of 100 is hardly any work. So this is a great mode for resting a patient. Right when you intubate a patient, is your goal to rest them or to start exercising them? Well, it's to rest them. So for immediate intubation, almost 100% of the time, and for me it is 100% of the time, my initial mode selection will be ACVC, where you guarantee given tidal volumes at the backup rate you set, and if the patient wants more, they don't have to do very much work whatsoever. Any questions about ACVC? This is one of the two most common modes you are going to see used, and I'd ask any old people in the room that have a little different twist on how to explain it to please chime in and do so. Okay, ACVC. The second one you're going to see used a lot is ACPC. So this is assist control, pressure control. Again, you set a rate, but instead of setting a tidal volume, you set two things. You set an inspiratory pressure and something called an inspiratory time. So instead of telling the machine to push in a tidal volume, you tell the machine to push in until the inspiratory pressure that you just set is hit. So the machine's going to push in until that inspiratory pressure is hit, and then it's going to hold it in for the duration of whatever inspiratory time you told it to. Of course, depending on how much pressure and how much time you apply, you'll get a bigger or smaller tidal volume. But you don't target a tidal volume, you set a pressure limit and set an inspiratory time. So how do you set the inspiratory pressure and the I time? It takes a lot of judgment. Like if I took any random person in the room here, nobody's very much more random than Mark Tancredi, and intubated him and chose a tidal volume right in that life-threatening situation of intubation, I would just choose 500 cc's. 500 cc's isn't going to be perfect for him, but it's not going to be terribly far off. I could give Blaine Knox next to him 500 cc's. Probably should have a little bit bigger tidal volume because he's pretty tall, but 500 is not going to be far off. So in ACVC, picking 500 cc's is a good place to start. I'm not sure how much pressure and how much I time will accomplish the tidal volume I want. So Right when I intubate a patient, I usually don't start with this because it takes some experience to pick the inspiratory pressure and I-time combo that is best for the patient. And what's best right at this moment might be different tomorrow. If somebody has bad compliance today, it's going to take a lot of pressure to get in a reasonably sized tidal volume. You diurese a patient, tomorrow the compliance is better. If you don't change the inspiratory pressure, they may end up with an enormous tidal volume. So ACPC takes some time and takes some experience to understand how to adjust those settings, and can vary day to day. Why do we ever use it then? Well, by definition, when you set a peak inspiratory pressure as the delivery mode, the pressure will never be higher than that. If you tell the machine push in a tidal volume, the machine's going to push in a tidal volume, come hell or high airway pressure. And if you chose a tidal volume that's maybe too big for the patient, the machine's going to push in, generating a lot of pressure and maybe causing a pneumothorax and barotrauma. In pressure control, you limit that pressure, so you minimize the risk of barotrauma. Secondly, in some patients, it's just more comfortable in a very variable and unpredictable way. You can't tell which ones will be more comfortable or not, but some are. And thirdly, you can imagine if you push the breath in and you hold it in for a little while, that may give more time for gas exchange. So in ARDS, we will frequently switch to ACPC. So ACPC, when you see it, what you're doing is every so often they get by the rate you set, they're going to get a peak inspiratory pressure applied, and that pressure will be held in for the duration of the inspiratory time. Questions about ACPC or old person's additions? Those are the two main modes you're going to see used in the Department of Medicine. One negative to holding a breath in for a real long time is you may not have enough expiratory time to get that last breath exhaled before the next one comes in, and that could lead to its own problems. Okay, so at the beginning, right when we intubate patients, our main goal is to rest them, so we typically use ACVC as our starting mode. You have to pick a rate, and if you're in assist mode, whatever rate you set, if the patient wants more breaths, they just barely have to generate some negative pressure to get additional breaths. So 12 is a reasonable place to start in terms of a respiratory rate. And then in ACVC, you have to pick a tidal volume. And the way you should do that nowadays is to choose a tidal volume that's roughly 6 cc's per kilogram of ideal body weight. Okay? 500 cc's works if you have an 80 kilogram person, but really we should be adjusting it in this fashion. And in terms of which weight, it's ideal body weight. If I gained 100 pounds, my lungs are not going to get bigger. So that's really based upon your height. So kind of every normal heighted person, if you chose around 500 cc's, you're not going to be bad off. But really, the new 2019 approach is to do it in a 6 cc's per kilogram fashion. And then you have to pick a PEEP. And pretty much everybody on Earth starts everyone on 5 centimeters of water PEEP. There is somebody who knows a little bit about ventilators named Martin Tobin on staff here, who starts people on 0 PEEP and only adds it in if the patient needs it for oxygenation purposes. And he's right, but the rest of the world just tends to put everybody on 5 a PEEP. And then we'll go up on PEEP if we need to in order to lower the FiO2 to a non-toxic level. How we titrate that, very complicated. No consensus to it, and a talk for another day. But starting with 5 is a reasonable place. And even if I took Blaine Knox sitting there, who looks pink, he's probably well saturated right now on room air, and I intubated him, right at the beginning, I would still put him on 100% FiO2, even though he probably only needs room air. I'm going to start on 100% FiO2 with the rationale being why leave a controllable variable uncontrolled during something as life-threatening as intubation. So I'll start at 100%, and then I'll rapidly come down, and you can do this too. You don't need to follow ABGs to titrate FiO2 as long as the pulse oximeter has a good waveform. If the pulse oximeter has a good waveform, you can just turn the FiO2 down every 5 minutes or so until you have a dropping O2 saturation. So if you gave everybody just kind of ACVC 12, 500, 500%, you'd be okay. The attending in the ICU is going to criticize your selection for some nuances, but if you started with these, it would be okay. Any questions about initial ventilator settings? Okay. So your job isn't ended once you get the patient intubated, okay? You've got to talk with a lot of folks. So in terms of sedation and pain control, half of intubated, let me just ask you this. How long does the anesthesiologist etomidate and succinylcholine last that they use to get the patient intubated? Jeremiah, do you have any idea how long it lasts? It lasts just long enough for the anesthesiologist to pack up their bag and walk out of the room. And as soon as they do, the patient's going to no longer be paralyzed. They're going to wake up. They're sitting bolt upright. You or the student are diving across the patient to try to hold him down. And it's your best interest to, as soon as you even imagine intubating the patient, to have a conversation with the nurse. You know, there aren't bags of fentanyl just sitting on the counters at the nursing station. It has to be ordered up. So you ought to have a discussion with the nurse about a sedation strategy. And 50% of intubated patients ultimately require no sedation. As a side note, I don't think I'm one of those 50%, and if you intubate me, I would like to be sedated, but it's said that 50% of patients don't need any sedation. And if you do apply just routine continuous infusions of sedatives, you ultimately delay extubation when the time comes. So the strategy should be PRN-based and preferably opiate-based dosing regimen for sedation. Benzos should be avoided unless nothing else is working. Benzos definitely delay extubation. And you titrate it not just by picking a dose, but to effect. And there's the Richmond agitation scale that you'd like to target a 0. You don't want somebody who's +4 like Doc Herring or -4 like some people in my lectures. You'd like to have a sedation where they're calm and alert regardless of what amount of sedation they require. You should anticipate hypotension at least right after intubation. Most intubated patients are hypotensive afterwards. The rationale is that right now we're all breathing spontaneously, meaning to get a tidal volume in, we expand our chest, which creates a negative intrathoracic pressure, and that increases venous return to the heart. As soon as you're intubated, it's the opposite. Each positive pressure breath goes into the chest and impedes venous return. So you should anticipate a little bit of hypotension. Usually 500 cc's of fluids will fix that. If 500 cc's of fluids doesn't fix the hypotension, then you worry more about things like a pneumothorax or other such complications. So make sure you have adequate IV access. Doesn't always equate to needing a central line, but you ought to ask yourself in every intubated patient whether a central line would be the safest thing for that patient. Think about how you're going to deliver meds, nutrition, chest x-ray. You're going to get a chest x-ray right then and there to confirm ET tube is in the right position. Nowadays, you shouldn't order one every day just out of routine, but instead you should use your judgment of whether clinical circumstances suggest that a new chest x-ray would be helpful. Talk with your nurse about restraints, their meds. You can just write an order to titrate the FiO2 so you don't have to fiddle with it. I think almost everybody, I'll say everybody would recommend getting an ABG once the dust settles and you have the FiO2 titrated and you think the ventilator settings are good. You can't assess pH or PCO2 non-invasively, at least not in practical circumstances. So one ABG. In terms of subsequent ABGs in an art line, it depends. If it's an easy stick and you're not anticipating frequent blood draws and frequent ventilator adjustments, you can just rely upon intermittent ABGs. If it's the opposite, difficult stick, shock, lots of blood draws anticipated, an art line would be in your best interest. And then pretty much everybody will get bronchodilators ordered at the time of intubation as well. Now, it may surprise some of you, but I haven't been the frontline person writing orders, and actually you don't write anymore, typing orders into Epic. So I would like some old people in the room to add any corrections or additions to immediate post-intubation Epic orders and communication with the nurses and respiratory therapists. Yes, Purnima. Okay, so there's a mechanical ventilation and sedation order set that makes all of this automatically happen? Has everything in it. Any CPRS nuances? leave that commentary for another day. Yeah, Maria? That's got to be emphasized a couple of times. And you say the respiratory therapists get in trouble if things don't match up. It's you who gets in trouble if things don't match up. It's important. You'll be in the room with an attending who probably at least thinks they know what they're doing with this and makes a change. It's your responsibility to get that change documented in Epic literally before you take your next breath. Because if we make a ventilator change and we leave the room, if something goes wrong with the patient, and nobody knew that a ventilator change had just occurred, they're not going to immediately look to that as the cause of the deterioration. So please put the order in, and you got to tell one other person, either the nurse or the respiratory therapist, whenever you make any ventilator changes. It sounds draconian. Your doctors, you got to be able to do these things, but for patient safety, document it in Epic and communicate it to at least the nurse or the respiratory therapist, if not both. Okie doke. Moving on. Oh, it's probably a nice idea to let family members know that their patient just got intubated. This happens all the time. You're on the wards, somebody decompensates, code blue is called, they're rushed off to the ICU, and you know what that room looks like at the end of that? It looks like a MASH unit. I mean, things are blown up, there's blood, there's stuff all over. Sometimes families walk in not knowing any better, and that's where they saw their loved one yesterday, and now they see that. So please communicate to the family. And make sure your attending on service knows that this happened as well. Okay. All right, emphasizing that as well. So, daily assessment, AKA how to sound like a doctor on rounds regarding the ventilator. Now, every attending has their own idiosyncrasies. I have mine. Mine just happen to be right. Okay, so this is how I would like you to present the ventilator information on rounds. I'd like you to tell me briefly the major changes since I saw the patient the day before. Like they coded or got a lung transplant. Might be a nice tidbit to throw in. I don't need to know that the potassium was 3.4 and we gave 40 milliequivalents, but major events, anything significant overnight, and how they're doing right now. Vitals, and I think a significant shortcoming sometimes is people say the blood pressure is stable without mentioning that they're on 4 pressors. Okay, so that's important to comment upon that. A very focused exam, and then we head to the ventilator. So you ought to give the mode, and if it's a control, the mode, rate, and volume together, and then the PEEP and the FiO2. Why? Because the mode, rate, and volume all have to do with how you are ventilating the patient, how you are getting air in and out of the patient. The mode tells you how and in what fashion, the rate, the volume, et cetera. The FiO2 and the PEEP have to do with how you're oxygenating the patient. And it literally will, if for humor's sake, you might present them out of order because I might seize. When you say the mode was assist control, the FiO2 is 40%, the rate is 12, I can't even say it. It makes no sense, okay? So present the settings in this order, and your ABG, pH and PCO2, which have to do with how you're ventilating the patient, and then your PO2 and O2 sat have to do with how you're oxygenating the patient. Okay, that's just a style thing. Then you're going to say how they're actually doing on those settings. You set a rate, but they could be breathing way over that. So what's their actual total respiratory rate? And then this is a little bit of the complicated thing, which if you're not like in the ICU right now isn't immediately applicable, but you all will be in the ICU, so please come back to this at that point. You will frequently report a peak and a plateau pressure, a resistance, and a compliance. So I'm going to go through the peak and the plateau pressure, although I know for most of you right now, you just wish we were watching the Cubs game or something. So what are the peak and the plateau pressures? Well, at the top, the part of the ventilator that has the airway pressure versus time curve, you will see the breath go in with the pressure going up, and the breath comes out, the pressure goes down to whatever your peak level was. So it's easy to see what the peak pressure was. The peak pressure was the highest pressure. If you press the inspiratory pause button, what happens is that on the next breath, the machine will push the breath in, but then it pauses for half a second, keeping the breath in for that duration of time before opening the valves and letting the breath out. So the breath went in, it's held in for a little bit, and then it's let out. So you have a peak pressure, just like before, but now you have this flat plateau appearing pressure, which is called both a plateau pressure and a pause pressure, adding to confusion. Now, why do we do those things? Is in order to help figure out how to get the patient off the ventilator. If the machine is generating a really high peak pressure to get a breath in, it's unlikely the patient would be able to be extubated because they're unlikely to be able to generate that same high amount of pressure. So you'd like to figure out why the pressure is high. And so I guess this is just another graph showing when you press this inspiratory hold, this is flow, the breath went in, it's held, and now it's coming out. So you get the peak pressure and the plateau pressure. The total peak pressure is due to a lot of things. The size of the tidal volume, the flow rate you sent it in, airways resistance, respiratory system compliance, all of those things can give you a high peak pressure. You take Tancredi again. If I strangled him, it would take a high peak pressure to get a breath in. If I stood on his chest, it would take a high peak pressure to get the breath in. The treatment for those two things would be different. So to figure out which the problem is, when you press the inspiratory pause button, it divides the total peak pressure into two halves. The pressure required to overcome resistance of the airways and a separate pressure related to the compliance of the respiratory system. So just one slide on math, and then we'll move on. You can calculate airways resistance, and you should, and you can calculate compliance, and you should, on your intubated patients in the MICU. The equation for resistance is pretty simple. It's the peak pressure minus the plateau pressure divided by this thing called the flow rate, which is enough to make most people in the room say, okay, I'm just going to miss that question on attending rounds. But unless you change the flow rate on the machine will be set at 60 liters per minute. The display will say 60, but that's per minute, so that translates into a 1 liter per second. So peak minus plateau divided by 1 is a pretty simple equation. Peak minus plateau, okay? And normal is less than 10. More than 10 means there's some component of airways resistance, which could be upper airway, which is unusual if the patient has an ET tube in, unless it's gotten crusted or something. More commonly, when you have elevated airways resistance, it means they need bronchodilators for asthma or COPD. Okay, the other equation is the compliance, which is taking the tidal volume divided by the patient's plateau pressure minus the peak. Like it might be 500 divided by 15 minus 5, would be the equation. And anything over 60 is normal. If it's less than 20, the respiratory system is super stiff, and that could be from two reasons. One could be the lungs themselves are stiff, as in fibrosis, or it could be a chest wall problem, like morbid obesity, massive pleural effusions, massive ascites. So if you found somebody has a really low compliance, you're going to get your ultrasound probe out and see if the patient needs a large volume paracentesis or thoracentesis. So, this is spending more time on a ICU-specific topic than I probably should have. But when the time comes and you're in the ICU, peak and plateau pressures, calculating resistance and compliance are things you're going to do every day. Just another slide describing that. When the plateau pressures are high, we want to make them low because your risk of barotrauma goes up the higher your plateau pressure is. It's not as though a cutoff of 32 is magical, in that a plateau pressure of 31 is fine and 33 you're doomed to long-term ventilator facility and a tracheostomy. It's a gradual transition, but around a plateau pressure of 32 and higher, the incidence of barotrauma goes way up. So if you have a high plateau pressure, you'll try to address that by giving a smaller tidal volume, lowering the PEEP, and conceivably lowering the flow rate. All right, so one more math type thing, and this is relevant because interns are often creative and will fiddle with one of the settings on the ventilator, even though I told you not to. And so we do need to cover one of the settings you're likely to touch, but probably shouldn't. So there's a normal flow rate, the rate at which a person inspires. All of us in the room here would inspire at an average rate of 60 liters per minute. The side note is how you get there is we breathe in about half a liter for a tidal volume, and it takes us about half a second to do so. So half a liter over half a second is a flow rate of 1 liter per second or 60 liters per minute. So why the ventilator is set at 60 liters per minute is because that's normal. Now, we're not all alike. We are not all alike, and not every patient is alike, so sometimes we will on purpose adjust the flow rate. But if you choose an abnormal flow rate, a different flow rate for no good reason, the patient's likely to be uncomfortable. Okay, so if you haven't seen it yet, on our ventilators, you will see what's called flow profile that can either look like a square rectangle or a descending ramp. Okay, those are on there. Blaine, how many times have you touched those? More than you should have, probably, okay? And why did you touch those? Okay, but why was it ever in the descending ramp wave to begin with? Okay, that's a good answer. Whether true or not, I don't know. So people who've been around know that, you know, I like to make a joke of what is, Schmug, do you know what the first rule of ICU medicine is? Make the beeping stop, okay? ICUs exist for the nurses and the monitors, and if none of the monitors are beeping, then probably everything is okay. And the number one cause of beeping in the ICU is that the peak pressure alarm on the ventilator is going off. So when the peak pressure alarm is beeping, especially at night, ramp wave ferries run through our ICUs. Those ferries come in different life forms. Sometimes it's the MICU nurse, sometimes it's a respiratory therapist, and sometimes it's a creative intern who has figured out that if you switch from the good old American square wave to a ramp wave, the beeping stops, okay? And why does that happen? Is that normally, if you don't change it, the breath will be delivered in what's called a square wave constant flow fashion. What does that mean? It means when it's time for the breath to go in, the ventilator turns on and pushes it in at a constant flow rate until it's in and then lets it out. It's on and off. If you switch to the descending ramp wave, now you can still give the same tidal volume, but it's going to do so in a generally lower flow rate, taking a little longer time, and as a result, the peak pressure will go down. So you're giving the same tidal volume, but you're delivering it over a longer period of time, and as a result, the peak pressure goes down and the machine stops beeping. And lots of time, that's fine. So I'm not telling you to never make that suggestion, but be aware of the consequence of it. So, because while the beeping is stopping, if you take longer to push the breath in, you may not have enough time for that last breath to get out. And if that happens, you can develop auto-peak. So you got to pick your poison. If you push the breath in really quickly, your peak pressures will be high, which we don't like. But if you push it in slowly, you may, this is trying to illustrate the breath going in and the breath coming out. It never got completely out before that next breath went in. That would lead to auto-peak. And that has its own problems. So if you're tempted to press the descending ramp wave button, don't. Have somebody else change it for you. Think about why you would be doing it is to make the peak pressure stop. And sometimes patients are more comfortable on the ramp wave. But be aware of the consequence, potential consequence of it in terms of auto-peak. So specifically in English, I'd worry about using a ramp wave in somebody who's prone to auto-peak, which is largely patients with asthma and emphysema. All right, one question here. This is our tidal volume going in. This is our square wave. And this is the airway pressure going up as the breath goes in and then coming down. What would happen to the airway pressure if the patient were to be breathing in at the time that the machine is pushing the breath in? Ideally with a ventilator, the machine pushes the breath in and the patient just relaxes and lets the breath come in and exhales. You know, we're wanting the patient to be rested. But what if the patient were to be breathing in actively while the machine is pushing in a tidal volume? What would happen to this airway pressure curve? Kevin Walsh, you know? It would go down. If the patient's breathing in, this airway pressure is going to be sucked down negatively. And so when you see this pattern on the airway pressure versus time curve, where the airway pressure isn't going up nice and smoothly like it should, but instead is getting sucked downward, that means the patient is activating the respiratory muscles throughout the inspiratory cycle, which generally is not what we want. We want to rest the patient. And in addition, if the patient's continuing to make a negative inspiratory effort throughout the inspiratory cycle, what can happen is that as soon as the ventilator stops pushing the breath in, the patient's still pulling on their own, it can create a negative deflection and auto-trigger the ventilator. So when you see double stacking or double triggering on the ventilator, it is almost always, and by almost always, I think always, due to the patient activating the respiratory muscles during that previous breath, which then leads to a negative pressure and a triggering of the next breath. So probably got carried away for what we should be talking about today, and I'm going to do that on one more slide. What's wrong with this graph? This is showing tidal volume in, tidal volume out, tidal volume in, tidal volume out. And we have here the airway, the flow going in and then flow coming out. You can see that on each of these curves, the expiratory flow doesn't reach baseline before the next breath comes in. If you see that, that's a sign of autopeep. Again, talk for another day, really, but you'll see this a little bit better here where there's flow in, flow out on the bottom, and you would like all flow to reach 0 before that next breath occurs. Here, that's not happening, so if you press the expiratory pause button on the machine, it will close the valves, not letting the patient exhale any further, and you can see the pressure go up at that point in time. So when you need to apply this in the ICU, come back and take a look at this. All right, so let's move on to more relevant things for every intern who's cross-covering patients in the ICU, which are troubleshooting things. So if your patient has high peak pressures, besides just turning to the ramp wave, I would ask you to throw caution to the wind and go look at the patient to see why the peak pressures are so high. You know, if they're agitated and thrashing around, well, that's why. If they're biting the ET tube, put on a bite block or get them some sedation or treat their pain, etc. If the peak pressures are high and it's not obviously the case that the patient is distressed, the ET tube has a suction catheter on that you ought to ask the respiratory therapist to pass through to see if it moves smoothly. Because if it doesn't move smoothly through the ET tube, it means something's blocking it. It could, again, be the patient's biting it. It could be kinked. It could be clogged. And if that's the case, you need respiratory therapy to put in a new ET tube. Check the peak and plateau pressures by pressing the inspiratory pause button, because if the problem is high airways resistance, your response will be to give them bronchodilators. Whereas if it's a compliance issue, you're going to get an X-ray to see what went wrong. And if it's none of those things and the peak pressures are high, you might just have to use a lower tidal volume, a lower flow rate, or sedate the patient more. Second thing, you want to make sure the ET tube is in the right position. You know, certainly right after the patient gets intubated, you order a chest X-ray, mainly for that purpose. What is the right position is for the ET tube to be somewhere in the trachea, but not right next to the carina. So you would like the distance between the tip of the ET tube and the carina to be at least 2 centimeters. It's worth noting that the tip of the ET tube mimics the position of the patient's chin. So if on the X-ray you can't see the patient's chin, it means that if the patient at some point lowers their chin, the ET tube would go further in, and the opposite. So when assessing proper ET tube position, the relevance is that if the ET tube was just like a centimeter away from the carina and you can't see the chin, that means at any point if the patient put their chin down, the ET tube would go right down into one of the main stem bronchi. So checking the ET tube position, and then you ought to, most people don't, but you ought to pay attention at what's called the corner of the mouth measurement of the ET tube. The ET tubes all have these measurements on there that tells you how far the tip of the ET tube is to that marking. And you ought to pay attention right when you know the ET tube is in the right place for that patient, what marking that correlates with. So in this example, if 24 centimeters is the right position, and tomorrow you come in to see the patient and the ET tube is now sitting at 22 centimeters, it means it probably has been tongued out of the patient, or vice versa. So somebody asks about the centimeter markings, you can see them on the ET tube. It is worth noting them in terms of following proper ET tube positioning. If the patient desaturates while on the ventilator, put them on 100%. If that doesn't immediately do it, disconnect it and bag the patient. Cuff leaks are when you deliver set tidal volume, but a smaller amount of tidal volume is returned to the ventilator. If that happens, ask the respiratory therapist to assess the balloon on the ET tube to see if it needs to have more air insufflated, or if that doesn't work, have anesthesia replace the ET tube. If a patient self-extubates, really your immediate response should be to just call Dr. Respiratory and have the patient reintubated. If you're there and you know the patient and you know that you had been kind of thinking of extubating anyway, it's okay to take that moment to see if, you know, that was the patient telling you it's time. It was their own set of weaning parameters. But your default position, especially at this relatively early part of your career, should be, if you're told the patient is self-extubated, is to ask for the patient to be re-intubated rather than fiddling around too much. If the patient has shock while on the ventilator, there's all the other reasons for patients having shock, but the two ventilator-related would be auto-PEEP and having a pneumothorax. So for pneumothorax, take a listen and order an X-ray. And auto-PEEP, you'll press the button on the machine as we were describing to look for that. Patient ventilator synchrony just means the patient isn't breathing comfortably, and that largely requires somebody with a bit of experience fiddling with the ventilator to try to make them more comfortable. And if by chance somebody has a fresh trach and the trach falls out, you should not put it back in. Instead, you should manage the airway like you would any other circumstance, having anesthesia come and intubate the patient. The reason being, and I bet for most of you this is obvious, but one person wearing a bow tie in the room here back when was moonlighting many, many years ago was cross-covering a patient that had a fresh trach. I got called by the nurse that the trach was sitting on the patient's sheet. So I came down, I took it, put it in the tracheostomy hole, went back to bed, and then the next day was yelled at by people for doing that. Luckily, it worked out okay, but when you put the tracheostomy tube through a fresh trach, who knows where it's actually going to end up. It may go through the incision in the skin, but could easily end up in the soft tissues or inside the chest in front of the trachea. It's actually rather unlikely that it's going to go into that hole in the trachea. So if a tracheostomy tube falls out, get the patient intubated for a fresh trach. People who have chronic trachs at home, they take them out and clean them all the time. But for fresh trachs, don't put them in. All right, kind of old people additions you'd like to add to things you were hoping I would cover regarding ventilators, tidbits. I am going to go through a little bit of weaning because that's kind of what we do here, but I'd be more interested in addressing questions from anybody. Okay. All right, I will cover in just 4 slides an approach to weaning, because Loyola is that's what we do here. And you ought to have a little bit of terminology on that. So, weaning, of course, is the process of getting the patient off the ventilator. The more proper terminology these days is liberating the patient from the ventilator, as opposed to a gradual withdrawal of something life-sustaining and nurturing, like you wean a baby from breastfeeding. We talk about liberating the patient. And the first step of that is a daily assessment. What I mean by that is there are patients in every ICU in the country that could be extubated today if somebody just tried. But sometimes when you're so busy with all the other patients, it's easy to just leave the patient on a PRN opiate dose and assist control than to go through the process of trying to wean. And the things that should say today's the day to try to extubate are if the reason they got intubated is gone, they're not in shock, they're on low levels of FiO2 and PEEP, they're mentating adequately, not even mentating, their respiratory drive center is adequate to trigger ventilation. You don't have to be reciting Chaucer to be breathing without a ventilator. I mean, look at a couple of people in the room here. And all of us at night when we're sleeping. And just no sense of badness. And so you really ought to ask every day for your patients if they meet these criteria. Then you're going to move on to doing weaning parameters. There are 2 that have stood the test of time. The rapid shallow breathing index, also called the Tobin index for Martin Tobin, the patient's spontaneous respiratory rate divided by their tidal volume. If it's way less than 100, you're pretty confident they're going to succeed on their own. And then the negative inspiratory force, anybody in the room here ought to be able to generate minus 100 centimeters of water pressure. If you can't generate at least minus 20, you're too weak to breathe on your own. So you check the weaning parameters, and then this is Tobin's article from '91 on that. His co-author is Amal Jubran, who's his fellow at the time. And then we'll move on to a T-piece trial here. So what is a T-piece? This is a T-piece. T-piece is a T-shaped piece of tubing that's put on the end of the endotracheal tube so that oxygen can still be delivered through the blue tubing and the patient can inspire that oxygen in. Just like after extubating, you can put a face mask on the patient. But this blue tubing is open to atmospheric pressure at the end, so there's no volume or pressure being delivered at all. It's basically turning the ventilator off and seeing how the patient does. And in a landmark trial, another of Tobin's from 25 years ago, it showed that the median number of days to achieve successful extubation was far less if you did a daily T-piece trial than if you fiddled with other modes of ventilation. And if you look at the the hardest to wean group, it was even more dramatic. So what I wanted to say about that is if you have a chance, Google Tobin, admire his awesomeness. When it comes to weaning here, every day you ought to ask, is today the day to potentially extubate the patient? You're going to check weaning parameters. Then we'll move on to a TPEAS trial. And if at the end of 30 minutes the patient looks good, we'll move on to a trial of extubation. So I will finish just by saying the general rules. Reasons people get intubated are non-quantifiable. It's the look that says the patient's going to die otherwise. We're going to talk a little bit about that tomorrow. Your goal is really to rest the patient, keep the pressures low. We'll talk about permissive hypercapnia another day, and we'll finish with that. I'll stick around if anybody has questions. I'm going to say tomorrow at noon, we're going to spend about 40 minutes talking about a general approach to the question of dyspnea. You as an intern get called by the nurse saying your patient is dyspneic and some general strategies for that. And then the last 15 minutes, our chairman is going to have a chance to say hello to our new interns. He wasn't here on orientation day, but I'd say more importantly in many ways, because this applies to the older folks in the room, he's going to describe our ready to launch, being launched global health track, which would have the opportunity for existing residents to apply for some time in either India or Africa at the end of this academic year. So I'd like you guys to be here so you can hear that described and see if it is interest to you. So you guys got other announcements you wanted to make? Okie doke, thanks for making it, or congrats on making it through 5 days.